different surgical procedures of the heart. So first off, there are 3 different approaches we can take. So first off is angioplasty. Second is a stent. And third is bypass. So first, let's talk about angioplasty. So angioplasty is basically, they're going to take a balloon and they are going to, it's deflated by the way, they are going to run it up through your groin through a catheter. And they're going to travel up to the blockage or the narrowing part of the artery. So what this does is they're going to go all the way up to this area of the heart where there is the narrowing of the artery or even blockage due to buildup. So what they're going to do is this balloon is deflated, like I previously stated. They're going to get the balloon right up against the blockage or the narrowing, and then they're going to inflate it. So what this does is it compresses that buildup. If it's for the case of buildup, it's going to, buildup, it'll compress it against the walls, basically flattening it. And I'm sorry about any spelling, about flattening it against the walls and opening that artery back up. And if it's for narrowing, it's basically going to stretch those walls in order to help that blood flow get back to the heart. So to draw a little picture, so this is your typical artery. So somebody that has narrowing, it might be very, very small like that. So blood flow isn't going to get through very well. And say you have somebody with blockage, their artery is normal size, but they've got some buildup on the sides. It makes that opening very narrow and hard to get through. So what the balloon is going to do is it'll come in and inflate those areas. It'll inflate this and help stretch and flatten if there's buildup or just narrowing. And then to finish the procedure off, they will deflate the balloon and remove it so that the walls will naturally stay open and the buildup will stay back. So the recovery time for this is usually pretty quick. Most patients are out of the hospital in 1 to 2 days, just depending on how their recovery time is, if the artery is staying open and clear of buildup. It's usually, if there's major buildup, it's not suitable for it. And we'll talk about another procedure that can be done if it's major blockage or narrowing of the heart. And unfortunately, sometimes with patients, reoccurrence, so it can come back. So that artery can narrow again and buildup can start to occur again. So what you do in this, or if this case pops up, that's what brings us on to our second surgical procedure that we can do, which is a stent. So what a stent essentially is, it's an angioplasty made like advanced. So it still uses a balloon, but now there is this coil on the end of it. So it's like a balloon wrapped in the coil. So balloon wrapped in coil. And what they do is they go through the leg. So same procedure, how to get to the area. Same way to get to the area. And what they're going to do is where that buildup or narrowing is, they're going to blow up the balloon And that coil that's tightly wrapped, the coil is now going to expand and undo basically. Again, sorry, cannot spell. The coil undoes and basically stretches out that area of narrowing. And also does the same thing of flattening out the buildup. But now, to prevent that reoccurrence of the buildup coming back or the narrowing, the coil stays in that area of the artery in order to help keep that artery open and wide for blood to be able to flow through. So just a visual representation of what the coil is it's very tightly wrapped. And what it does is it will get to that area and basically expand open. So now that blood flow can travel through here nice and easy without any narrowing or blockage getting in the way. One risk that typically can associate with this is where there's a foreign object in your body, the coil, blood clots can occur around it due to it being an object and not the smooth flow of your artery. So that is common, so that's just something to watch out for. But typically the recovery time with this is about the same as angioplasty, since it's just going through the growing and doing it. There's no really major surgical procedure. But if neither of these seem to work, or if your case of buildup or narrowing is too severe, that brings us on to our third surgical procedure we can do, which is a coronary artery bypass. Or just simply known as bypass surgery. So what this is basically, it does require open heart surgery. So already your recovery time is going to be much lengthier and a bit more difficult because of the open heart surgery. So just to familiarize you with the open heart surgery, basically what they have to do is go through the chest. So they have to go through all the layers of skin, muscle, and bone, and basically crack open your chest in order to get to your heart because it's so protected. And the reason they're getting to the heart is because what they're going to do is you're going to have your blocked artery. So if this is our artery and it's completely blocked, there's no getting through here. What's going to happen is now the balloon is not going to work, and putting that coil in there is not going to work because there's no way we can get it open anymore. So what they're going to do is they're going to take a saphenous vein from your leg. So saphenous vein. From your leg. And they're going to basically harvest it, and they're going to take it up to your heart. So let me draw you a quick picture. So if this is our heart, and this is the blood coming to it, but unfortunately we have this big blockage right here. What we're going to do is they're going to take that saphenous vein and they're going to place it right before the blockage. So they're going to place before blockage. And basically attach it to the artery that's already present in your heart. And they're going to run that saphenous vein around the blockage on the same artery still. Run around blockage. And then bring it out in front of the blockage. So what that means is, so bring out in front of blockage. So what this does is it goes around that area of blockage or narrowing, and since it cannot be removed or stretched, they take that saphenous vein and go around so that blood flow, instead of it hitting this and not being able to go anywhere, it can now travel through the saphenous vein and around and back out in front of it in order to get blood to that artery and to the heart. So typically this recovery, like I previously said, is a much more lengthy one because of the open heart surgery aspect and the harvesting of the saphenous vein. And depending on like how bad your blockage is, you could require multiple bypasses. In the long run, just depending on how bad your blockage or narrowing of the artery may be, it depends on what kind of surgical procedure you will require. So again, let's review. If it's just as simple like narrowing or a little bit of buildup, you can do an angioplasty, which is they go through your growing with a catheter and they blow up a balloon in order to stretch out that area and flatten out any buildup, and then they deflate it and remove it. But the downside with this one is it can reoccur with the shrinking or the buildup. So another option that could be potential is a stent, which is again the balloon through a catheter up your growing, but now it has a tight coil wrapped around it. So when it gets to that area, it can release and stretch out and again flatten that blockage or open that area. But now that there's a permanent object there, it helps keep it open. But the downside is blood can clot around this area. And then if it's very severe or the other two options did not work, there is bypass, which requires open heart surgery, and it's taking that saphenous vein to go around the blockage in the artery and come out in front of it so that blood flow can return back to that area and get to the heart. The only downside is this does require open heart surgery and takes a longer recovery period. And if the blockage is so bad, numerous bypasses will have to be done. Just depends on the severity of your condition or what your doctor requires. Drawing the heart. So you have like this potato shape, and it's broken up into 4 sections. So you have your right atrium, your right ventricle, your left atrium, and your left ventricle. So first of all, up here in the corner of the right atrium, we have this little thing called the SA node. So what the SA node does is it's going to send a signal across the atriums in order for them to squeeze downwards to let blood travel into the right ventricle. What happens is this signal hits right here, which is known as the AV node. What happens when it hits the AV node is we get this delay. So AV nodal, apologies for spelling, nodal delay. So what that is basically it allows time for the right atrium to squeeze down to get the rest of the blood that did not already passively fill into the ventricles in order to successfully fill into the ventricles to be expelled. So what happens is this AV nodal delay, the signal hits here, which is basically just the buildup of dead cells. Once it hits here, it travels down on this line called the bundle of His. This travels down the ventricles in order for the signal to then break off into the left and right bundle branches. So the bundle of His is like right in here before it breaks off into the left and right bundle branches. These will travel down the ventricles and around into these things called Purkinje fibers. So what the Purkinje fibers are is it's responsible for the squeezing upward action of the ventricles for blood to be expelled out into either the lungs through the right ventricle or out to the body through the left ventricle. So the signal is carried across the heart, again, starting at the SA node, down across the atriums, in order for them to squeeze down for blood to fill into the ventricles, hits the AV node and hits the dead cell or layer of cells, which causes AV nodal delay in order for the rest of the squeezing to be done by the atriums, in order for it to fill into the ventricles with what wasn't done in passive filling. Then hits the bundle of His, where it will then separate into the left and right bundle branches to travel down the ventricles and around to hit the Purkinje fibers, which go up the ventricles in order to help squeeze the blood up and out, unlike the atrium, which is squeezing down. So, one main thing that can happen that happens during muscle contraction is conduction of the heart. So what conduction is it's basically a cell-to-cell depolarization. So a little picture. So say you have a cell here and then cells here. So this cell is depolarizing, and these are still currently polarized. Well, what is happening with conduction is the depolarization is going across through to the cells in order to help depolarize them down through the heart. So what's taking place in this action of depolarization of the heart is, as the SA node receives the signal and sends the signal across the across the atriums, this process is happening in each individual little cell of the heart. A bit more about conduction is that it is actually what is taking place in the depolarization through the SA node, AV node, and down. So what it is it allows time for the atriums to contract before the ventricles contract. So what it's doing is keeping the heart on a constant rhythm of contractions and preventing any arrhythmias. So an abnormal conduction is basically the heart doesn't follow a correct pathway or rhythm. So what can happen is you can have things such as tachycardia, which is the heart is depolarizing too fast, causing the ventricles the atriums to squeeze and then the ventricles really quick. So basically tachycardia is too fast polarization or depolarization. And then you can also have something called bradycardia, which is where it doesn't depolarize fast enough. So what happens is the signals received here in the SA node travel with bradycardia. Let's start there. With bradycardia, the signal is received very slowly across the atriums. And when it hits that AV node, the delay can be even more causing for the ventricles to not contract when they should be, when the blood has filled to 100%. With tachycardia, on the other hand, AV nodal delay will not doesn't take place long enough. So before filling can completely occur, the ventricles are already squeezing, sending blood out of the body, causing for that fast depolarization boom at the body. And with AV nodal with conduction, basically for a normal, it allows for that AV nodal delay for the depolarization down on the bundle of His, the bundle branches, and the Purkinje fibers in order to help the heart have a normal rhythm and beat, versus if there is abnormalities, it causes the too fast with tachycardia or too slow with bradycardia, causing there to be an issue with the rhythm of the heart. heart failure. So what is heart failure? It occurs when blood flow is no longer being supplied enough. Blood flow supply not enough to where it should be in the body. So places like the brain, the legs, anything like that. So the blood flow, like the heart is unable to meet the amount required, and it's just not getting enough out. So there are two main causes of heart failure. So first we have coronary artery disease. So what that is basically blood flow is reduced in the coronary arteries, hence the name. And this means that oxygen is not being delivered to places where it needs to be. Again, like I previously said, the brain, the legs, anywhere that requires oxygenated blood. Another example, or another cause, is a myocardial infarction, or in layman's terms, a heart attack. So what this is it's broken down in, or how we can better describe heart failure is broken down into systolic and diastolic. So what this is systolic can be referred to, which I'll go over in a second, HEF, REF, and diastolic can be referred to as HEF, PEF. So first let's go over what systolic failure is. So what is systolic failure? It's basically the cellular signal that is being sent out through the heart is now impaired and causes inotrophy. So the ejection fraction is now reduced, which is where we get the term ref from, because of this right here, which is ejection fraction. Heart failure, ejection fraction. So the heart is no longer able to get blood out of the body. So what is happening is your stroke volume is now decreasing because the heart is unable to gain that power with the inotrophy being impaired, and the heart can no longer supply the amount of blood. So your stroke volume goes down, and now preload. So with stroke volume going down, your preload now is increasing, causing stress on the heart. We can also look at the Frank-Starling mechanism. The Frank-Starling curve, and now it's shifting. So Frank-Starling curve, it's now having a downward shift, which means that the heart is no longer, it's becoming exhausted, and the sarcomeres within the heart, the muscles and all the fibers, are now, so sarcomeres are stretched to their limit, and the heart cannot take any more. So that's why that curve is going down, because it's at its maximal amount, what it can do, and the heart is starting to give out. So we're getting that ejection fraction is not occurring as it should be. So the blood is not leaving the heart at the rate it should be, or in the amount. So that causes, like we talked about up here, it can be, or for heart failure, the blood supply is not enough because it cannot leave the heart. Now, for the other heart failure, we have diastolic, which is basically, it's the second type of heart failure that can happen, and this is caused by ventricular filling. Something is going wrong in there. There's something that's impairing this type of, that is like stopping the ventricles from receiving their amount of filling. So with this type of failure, the ejection of the blood is not reduced, unlike you have in your systolic, which is where you get your ejection fraction. In this case, it's your ejection fraction is actually preserved. So what that means is the P in HFrEF, or HFpEF, my bad, is the preserved. So whereas in HFrEF, you have just an issue in general with the ejection fraction, in HFpEF, you're getting 50% or more is staying in the ventricles. Which is causing ventricular hypertrophy because there is so much blood staying back in them. So ventricular it's causing ventricular hypertrophy, which can then lead to hypertension, and which is based on a pharmacological level to help prevent HFrEF and HFpEF. Well, first off, let's start with HFrEF. So if you're experiencing or believed to be experiencing this, somebody will administer, or a patient that is experiencing HFrEF, they will get a combo of drugs that will help reduce your preload of the heart, the afterload, reduce the afterload, and help reduce your blood volume. All of these things are helping to have less strain on the heart, so less strain, so the heart isn't working as much. And isn't overdoing it as it is trying to pump out all that blood and trying to get it out of the ventricles and overworking it, causing that Frank-Starling curve to occur and the heart being stretched at its limit. So these drugs can help bring down that preload, the blood volume in the atriums, or in the ventricles, and the afterload after it's ejected out. So with HFpEF, there's not really much that can be done, unlike HFrEF, with the different drugs to help reduce those things. With HFpEF, you mainly can just get calcium channel blockers, and beta blockers. So basically what these calcium channel blocker and beta blockers, the benefits of them is they're helping to control the symptoms of HFpEF, so they're controlling the symptoms. And reducing the risk of heart failure. For someone that might be experiencing signs, and it can help improve somebody's morality of finding out there's a chance to help prevent heart failure or going into it. Unfortunately, HFrEF and HFpEF are irreversible, but they can be prevented from somebody going into heart failure, or by slowing down the causes by using either someone with HFrEF using a combination of drugs to help bring down those three elements, and somebody with HFpEF to bring down, or to use calcium channel blocker and beta blockers to help control those symptoms and reduce the risk of heart failure, which again, heart failure, to review, is blood is not being transmitted adequately to places in the body it needs. Therefore, oxygen is not getting to places such as your brain, or different parts of the body. So how can we detect if somebody is having heart failure or having HFrEF or HFpEF? Well, this is where imaging comes into play. So first of all, we have this type of imaging. So what imaging is it's basically a way for us to see inside the body what our human eyes cannot see. So first, let's talk about an echocardiogram. So what is this? It's an ultrasound of the heart. So what that means is it allows us to be able to look at how the blood flows. Allows us to look at how the blood flows throughout the heart. So how this is beneficial for heart failure is, again, it allows us to see, is that blood adequately being pushed into the body? So is it traveling to the body? So with this, we can see as the blood is being through the atriums to the ventricles, out to the lungs, back in to get oxygenated and out, or through the atrium to the ventricles and out to the body. Is that happening? So an echocardiogram is very beneficial in this way to help us determine, is somebody in pre-heart failure? Some challenging things that can happen though with this, or with imaging for the heart, is you have to think the heart moves every time you breathe. So let's talk about the 3 main issues. So like I just said, the heart moves. So as you breathe, the heart, it gets bigger and smaller, and as the blood is traveling through it, you have the movement of that occurring plus the breathing, which is point 2. Every time you take a big breath in, your heart expands because of your diaphragm. And every time you let out, it shrinks back up. So this causes issues in imaging because the heart is constantly growing and shrinking in size as you're breathing. And lastly, we have how it is on its axis, how it's positioned in the heart, or in the body. And the size. Each person is different. You have to think, as somebody is much taller, or let's say you have somebody that is 6 foot versus somebody that's 5 foot. Somebody that's 6 foot has more room in their cavity, so their heart is going to be more vertical up and down, versus somebody that's 5 foot, it's going to be smaller. So say we have our person's chest here of our 5 foot patient. Their heart is going to be more to the side because there's less room for it in the cavity. Versus if we have somebody that's 6 foot, theirs is going to be more vertical because it has more room to be up and down. And this affects how it's positioned in the body. So the issue with imaging is no 2 people are alike, so it's always going to be different in how the heart is placed and where it is. But some benefits of imaging is it can give us different views of the heart. So the 3 main ones, so you have different, so we have 3 main ways. We can see it transverse, the frontal view, or better known as coronal. Don't know if I pronounced that right. And sagittal. So transverse allows us to see the heart basically cut in half. So cut in half. Frontal gives us just the front view of the heart. So if we're looking at it, it gives us a view of how we can see it flow through. So how you see like all your pictures. So pictures of hearts. And then sagittal, we can see it from the side. So these are all beneficial in helping us determine if a person is entering heart failure or is already present with HFrEF and HFpEF, because again, it can tell us how well the blood is flowing through the heart. Is it staying behind in that ventricle? Is it being expressed out? Well, how is it traveling through the body? Are we going into heart failure because adequate blood flow is not reaching? These all can be determined by just one simple imaging of an echocardiogram, and there's many more out there that can help and be beneficial in different terms of issues or with different types of heart or issues. So when you're looking, you can have an MRI, which is best for your soft structures. So if we're looking at the walls of the heart, how, like, if they're built up, are they been broken down and stretched too much? We have your CT scan, which is a very detailed look at the heart, but mainly in this case scenario, an echocardiogram will be your best bet to look at the heart, because it'll show you that blood flow and tell you, is this person into heart failure? Do they have HFrEF and HFpEF present?